Hello, and welcome to another conversation with Carl. Remember, for the latest content, please follow, like, and subscribe. Today, we are honored to welcome Dr. Laura Esserman, an internationally recognized breast surgeon, breast oncology specialist, and visionary in personalized medicine. Dr. Esserman is revolutionizing breast cancer screening and treatment throughout our nation today. As a professor of surgery and radiology at the University of California, San Francisco, she is calling attention to and finding solutions for the overdiagnosis and overtreatment of breast cancer, and because of her work, was included as one of Time Magazine's 100 most influential people. Welcome, Dr. Laura Esserman, to the conversation.
Thank you so much, Carl.
So I would like to start with talking about a very important event coming up that is called Rise Up for Breast Cancer and Women's Health. It's an interdisciplinary breast cancer and women's health conference in San Francisco, February 19th to 21st. And you can register by going to riseup.ucsf.edu. Would you like to tell us about this event?
Sure, I'm happy to. I'm very excited about this meeting because it is forcing us to think a little bit differently. And some of the ideas we had in mind when we started this conference actually now are possible. So the idea is to try and rethink all of the interventions that we do over the course of a woman's lifetime and think about how can we rethink these with an eye towards breast cancer prevention. You know, we are at a precipice now. The wisdom study results are out and show that personalized screening not only is possible, but it's safe and it's actually more effective at identifying people with, at preventing more locally advanced breast cancer, stage 2B cancers. So I think over the next year or two, we're going to see a transition in screening to thinking about how we identify people at high risk. Well, that means, that we have the opportunity to find these high-risk women, and we need to be thinking about, should that affect the way we think about birth control, cycle control, IVF, hormone replacement therapy, treatment of endometriosis or fibroids? And in fact, many of these conditions kind of overlap, and some of the treatments that we might want to push forward may actually be breast cancer risk reducing. And in our high risk women, we're already going to be screening people more intensively. So we want to be able to really change our infrastructure to be able to routinely identify high risk people, try and get them to do things that will reduce their risk, but also try and think about the everyday things that we do for women and find a way to make those also an opportunity for risk reduction. You know, there's so many questions people have these days, and there's been a back and forth. It used to be that everybody got hormone replacement therapy until the Women's Health Initiative kind of showed that the combination of estrogen and progesterone was increased the risk for breast cancer, and there was a big drop off. And there's been recently this huge explosion of people being given progesterone and estrogen combined. But again, one size doesn't fit all. One size doesn't fit all for breast cancer treatment. It should not be one size fits all for screening, and it shouldn't be one size fits all for treatment. For prevention. So it's not going to be one size fits all for what you need when you have symptoms of menopause or when you have endometriosis. There are so many more options that we have today, and we can be much more thoughtful about trying to do more for the people that need it, less for the people that don't. You could worry more about certain things if your risk is high and less if you don't. And this is about getting the oncologists, the surgeons, the OBGYNs, the primary care physicians, the advocates, and everyone together to have a different kind of conversation. So it's very exciting.
What do you think the conversation should be? So, I wouldn't show up to you if you wouldn't be my doctor. But if you're a woman and you showing up.
Well, you might have a BRCA2 mutation in your family and be worried about breast cancer. Yeah.
Yes.
Even for a man. Yes.
So even for me. So if I show up, what should you be looking at?
Well, I think let's talk about the wisdom study for a minute. So our hypothesis was that, again, breast cancer is not one disease. It's many diseases. We don't treat breast cancer the same. We look at biology. We look at the timing of recurrence. We look at the types of cancer, the type of cancer that it is, and which particular types of therapies we might use to reduce your risk. And, all of all of those features actually impact even how we follow people up after cancer. And, the problem with our approach to screening is that it started in, the 80s, 90s, before we knew anything about breast cancer. And what we decided was, you know, the way to approach screening is when someone turns 40, we should start screening them and everyone should get the same screening. But that makes no sense, right?
Yes.
We shouldn't treat it as one size fits all. And so we said, there's probably a much better way to go about this, and we can personalize screening based on risk. So the most important thing to do is to start with risk assessment. And for that risk assessment, we felt like it was critical to include genetic testing, population genetic testing. Not whether you had family history, not whether you had anything else, but to look at a couple of things. Did you inherit an error or a pathogenic mutation or pathogenic variant, that's what they call it, in one of the genes that we know definitely increases your risk for breast cancer? And even those aren't all the same. Some are very high risk and some are moderate risk. And then there's a whole bunch of other genes that you inherit. And we can put all those together by themselves. They don't mean very much, but as a group, many, genic risk, PRS, or a polygenic risk score, can also help us understand whether you're at more risk or less risk. But really, in a very important and exciting turn of events, we can also start to understand what kinds of cancers you might be at risk for.
Okay,
So
now
then you start with risk, and then we include a model that's been well calibrated. We use the Breast Cancer Surveillance Consortium model. So that includes density, biopsies, all the other things that are in the other models. And we put that together and say, okay, are you in the highest risk group? Are you in the elevated group? Are you in an average group? Or are you really in a low risk group? And it turns out that, lo and behold, which group you're in, you can really stratify the risk. We actually randomize people to the risk-based approach versus an annual screening starting at 40. And if people didn't want to be randomized, we allowed them to join an observational group and choose which arm they wanted. But we really did the analysis looking at the people who were randomized, because that's supposedly the gold standard. But we wanted to include everybody who was interested in the study. And I'll get back to that in a minute. So in the people who are randomized, there were the same number of cancers in each arm. But the highest number were in that highest risk group, the next highest in the elevated risk group, then average, then low. So the lowest risk group had the lowest number of cancers. This makes sense. Now, it's not perfect. It's not like we found a group where nobody had any cancers. Over time, hopefully we'll get there. But what's really important is those people in the lowest risk group don't need to start screening until they're 50. And that's about 2/3 of the women in their 40s. Why is that important? Because you have the highest number of false positives. People get called back for biopsies, which are really scary and unpleasant. And sometimes you can find little things and you're not sure what to do about them. And that's one of the things that can lead to overtreatment. But on the other hand, if you look at the very highest risk group, we assigned those people, and there was really a small number of people, 2% of the population, and we assigned them to screen every 6 months. In that group, because we had assigned them every 6-month screening, there were no stage 2B or higher cancers. We really reduced the number of bad cancers that were found by identifying that highest risk group early. Now, in that group were people who had inherited, these so-called pathogenic variants. And what's important about that is 30% of the people who had them did not have family history. That's really important. And again, it's the wrong standard. We've used family history as a way to say, let's find out who should get genetic testing. That's not true. Most people can get genetic testing. It's a little spit kit. We send it to people's house, and they mailed it back. It's absolutely feasible. It's a one-time test. It's cheaper than a mammogram.
Is insurance paying for that?
Well, not yet.
Yes.
I'm hoping that this data from the Wisdom study will cause a sea change. And then we actually will be able to have the information to find the people at highest risk. And we can screen them appropriately. We can do interventions to reduce their risk. I mean, I think this is really exciting. And it is, and not only that, it's going to be, I mean, this is a win-win for everybody. It's a better way to use resources. It's more cost effective. And it's not that you're trying not to spend the money on people who need it. What you want to do is make sure that you're doing more for the people who need it and that you can ratchet down the intensity for less, and when people who are at lower risk. And this is going to be true. I mean, we accept this in the area of colon cancer screening, right? If you have a colonoscopy and you don't have any polyps, you're told to come back every 10 years. No one says, oh, I demand to have my colonoscopy next year. No, nobody's saying that, right? And not only that, we would even, if we said, oh, we're going to do colonoscopy on everybody every year, we couldn't do it. It's just like we can't do MRIs and mammograms every 6 months on everybody in the country. It would cost like, $80 billion. I mean, that's just not a reasonable way to put your resources to work. And resources are a proxy for, what you have to go through to get screened. If your risk is really lower, great, you can do less. I mean, everyone should always be vigilant. That's, and be aware of certain signs and symptoms. If you feel a mass, you go in no matter whether you had a normal mammogram, whether you were told you were low risk. That's just sensible, right? So no test is going to be perfect. But by and large, it really works. You have many fewer cancers in the low risk group and many more in the highest risk group. And now we want to really do is by being able to start with risk assessment, you can really double down on prevention. Find the people who will benefit most from things that we can do to lower risk. That's how we've brought down the risk of heart disease, right?
What do you mean by prevention? Because either you have like cancer or you don't. That's the way I see it, but you're going to tell me it's different.
No, that's actually not true. So let's take something that everybody's familiar with. They go to their doctor, they get a risk score, they look at their blood pressure, they look at their cholesterol, they have a conversation. Are you at risk for heart disease or not? If you have a family history and your cholesterol is high, you're often recommended to take a statin. And why? Because it reduces the chance that you might get a fatal heart attack or a stroke by a third. And that's true even if you don't have a family history. So that has been one of the things that's really allowed us to bring down the risk of dying of heart disease, right? Which is the most common killer in the country, right? But we can do the same thing in cancer. So if we know that you are at risk for a relatively slow-growing hormone-positive cancer, we do have medicines. There's lifestyle things you can do and medicines that can reduce that. And it used to be that people would be recommended tamoxifen. This is it's a standard hormonal medicine that we use for women with breast cancer. And one of the things that Andrea DeCenzi did from Italy, he demonstrated that you can use a quarter of the dose, baby TAM, 5 milligrams. And it makes almost all of the side effects go away. And the thing about it is, if you took it and it didn't bother you, why wouldn't you want to take it if you knew you were at high risk? Another thing is you might not want to do combined hormone replacement even if you were having a lot of hot flashes, because that would increase your risk. But there are lots of other things that you can do. You can make important decisions. Wait, what are the other things that we know reduce the risk of breast cancer? Diet, exercise, weight control, not drinking too much alcohol. These are all things that we can do to reduce the chance that we get breast cancer. I've spent my life treating women with breast cancer and trying to come up with innovative ways to make the therapy less toxic and better and more effective. But even better than that would be to reduce the chance that people would get it at all. And that's where I feel like we are on the precipice of this revolution of being able to do that and be able to take the tools that we have, mammographic, AI, now we'll be able to add these sort of density algorithms. There's another big myth that's out there. And, everybody, and it is important that breast density is one of the risk factors. But it's only one of the risk factors. And the tools that we have now are pretty crude. They'll say, well, if you have dense breast, you should get extra screening. But if you go get an MRI because you have dense breast tissue, that's 50% of the population will be suggested to get supplemental screening, which is probably not going to help them. When in fact, these new algorithms for looking at density, which are better than the human eye, really I can identify the 10% of people who need to get additional screening. And these tools can also make the detection better. So I think we want to be able to use all of these tools and technology, but we want to use them in the best way. And I think these tools over time will also be good ways to help us learn how to reduce risk. Kind of like the cholesterol for breast cancer, right? A good
Yes,
measure.
correct. What you talk a lot about overdiagnosis and overtreatment of breast cancer. Can you explain that?
So I think one of the big concerns about screening, and many, many people have written about this, not just me, is that when you are if you are looking extremely carefully, you will find things, but maybe you'll pick up kind of what we would call indolent, as I like to call them, shoplifter cancers, things that probably aren't on their way to causing a big problem. But once you find them, you can wind up doing way more than people need. A good example of that is ductal carcinoma in situ. It's a precancer. It's not invasive cancer, and people don't die of DCIS. Uh, by and large, it's 99% will not. Many, many of these are probably overtreated because some of them are just risk factors. And there are other things we can do to reduce the risk factors. So I, in fact, am running another big national study called Recast DCIS. This is an opportunity to think about active surveillance. Can we be studying some of the new endocrine medicines and tested against something like baby TAM and see, can we start with, using an MRI and seeing what happens over a 6-month period of time? And if it goes away and gets better, there's a very good chance you'd never have to have surgery, radiation. We can, so who has surgical disease and who doesn't? So many people wind up getting overtreated. This is not unlike prostate cancer. I think everybody knows that story better, right? One of the reasons why people got nervous about screening for prostate cancer was that we found all kinds of small, low-grade cancers, especially when you biopsy the prostate, you find these low-grade cancers. And doing a prostatectomy or radiating the prostate has very significant long-term consequences. And what you really want to do is find the consequential cancers that are on the road to killing you. It seems strange that the word cancer could be
Might
used with
not kill you.
something that
Yes.
might not kill you.
To
Like,
kill
oh,
you.
wait a minute,
Yes.
I thought a cancer was something that if I didn't treat it was going to kill me. But
Yes.
thyroid cancers are another good example of that. Cervical carcinoma in situ, we used to call it cervical carcinoma in situ. They got rid of that name because they were finding all these abnormal cells on pap smears and people were getting hysterectomies, right? So that is really the whole consequence is really trying to understand, as we learn more, we can put people into, okay, you have a category of risk. So if you have HPV, for example, you might be at risk for cervical cancer and you might need to be screened more. Or if you don't, then you might need to be screened very little, like every 5 years. If you have a PSA of less than 1, you probably will never get a prostate cancer and you probably don't ever need to be screened. But then the rest of the people can get screening where it might actually save their lives. So we can't just do a blanket, oh, we're going to look for everybody, because then you surface all kinds of stuff that may not be destined to kill you. And so people have to understand that cancer itself is complicated and cancer screening is complicated, but that doesn't make it bad. I think it's a huge opportunity to make things better and for us
So,
to put our resources into reducing the chance that you would get something that would kill you.
so how does psychology play into this? Because as a lot of people I know are all told to, go get screened, go get screened. And now you're doing something revolutionary, which is like, let's figure out your risk factor before we decide.
Yeah, but
And how
when
does,
you
yeah,
stop and think about it, it's not really that revolutionary. We use risk assessment in almost everything we do. How many people are part of the TSA pre-check? You've been screened, you put in a lower category, and you get to go through your screening better and faster. Same thing for global entry. The same thing for heart disease. The same thing for many of these things. This is just sensible. Now we're starting to develop the tools to be able to make it possible. I mean, yes, it's definitely a change, and we have to work on it. 40 years of public health messaging is very hard to undo. And people, I think that we needed to do the first part of the wisdom study to show people, wait a minute, if we stop screening people in their 40s, but we were judicious about it and picked the people at low risk, we weren't going to see a big increase in people showing up with late stage cancers. In fact, it turned out just the opposite. We actually, with fewer mammograms and fewer biopsies in the people who are at low risk, you can actually reduce the number of bad cancers that people get. We can't be satisfied with where we are. There's close to 330,000 women being diagnosed every year in the US, and 40,000 women a year are still dying. Who can be satisfied with that? That's no good. So we have to do better at figuring out, how do we bring that number down? And how do we bring the death rates down? I think, just if you extrapolate it, if everyone did risk-based screening, and we did this, we all adopted it tomorrow for less cost and less pain and suffering to women, we could probably reduce the number of stage 2B cancers by 4,000 or 5,000 a year. We could reduce the deaths from stage 2B cancers. That's
it's a lot.
a lot. And so what I would say is that risk-based screening is the beginning, not the end. And, there are new and exciting medicines that aren't standard chemotherapy that we're able to test for people up front. As a surgeon, I've also pioneered starting with, if you have a bad cancer, surgery is not the answer. Making sure you've got the right medicine and it's going to shrink the tumor is the most important thing you can do. So you start with that. We call that neoadjuvant therapy. And with that, you can reduce the chance that someone needs a mastectomy. You can reduce the chance, you can give people their life back, knowing that I had a good response and I don't have to do more therapy. We're now working on trying to find out ways to be able to sequence things so that you don't have to take standard chemotherapy if you can get a treatment that works up front. We shouldn't be satisfied with where we are. Our treatments are toxic. Our therapies don't work as well as they should. Our patients don't have the patience to wait, and nor should they. We need to really work on finding better solutions now.
How do insurance companies play a role in this? Because you sound like, this sounds revolutionary to me, and it sounds like we're changing the way of what we've done for the last 40 years.
Mm-hmm.
And I'm sure insurance companies have a lot to say.
So I hope that the guidelines will change and that the U.S. Preventive Task Force will say, yes, that this is something that we can go forward. I know that NCQA, that does the whole HEDIS data sets, they're actually big fans of this. I expect to see over the next year the NCCN guidelines change, and it will take time, but I do think that the genetic testing will become standard. And we have to work to find ways to show. I think the insurance companies are worried, people are just going to do the genetic testing and then they're going to do the extra screening. Well, I think that risk-based screening isn't just a test. Risk-based screening is an approach. And I think what we have to do is think about, what does this approach mean? This approach means a risk assessment that includes genetic testing, but part of that then comes in to give you support to understand, what does it mean? Can I do less? Do I need to do more? If my risk is up, what are my options for prevention? This needs to be part of an integrated program. So it's a product, and it's not just like a lot of these new tests that get thrown on the market, like the multi-gene testing or whatever, that you do a test, well, then what do you do if it's positive? That's not helpful. So you have to put it together. In our trial, we had a group of breast health specialists. We had genetic counselors and breast health specialists. So if we found people at high risk, we reached out and talked to people to counsel them, to help them. And it's not the majority of people. It's, 10% of the population need that. right? But they need to know what they need to do and how to do it. And we built decision support tools. But we also, to your point, we have to help educate people and make them feel comfortable that it's just as safe to do less when your risk is lower, and how you can do that. But what are the things you should still be vigilant about? So this is all part of change management. So, I thought running the trial was hard, but actually figuring out how to implement is going to be even harder. Now, one thing that was very interesting is that, now obviously we were randomizing people 1-to-1, starting at 40 or doing risk-based screening. But in the people who didn't want to be assigned, randomly assigned, and the people who chose, 89% of people chose risk-based screening. And that was true regardless of age and regardless of geography. Even in the Midwest or the South, it didn't matter. And so I think that people like the notion of having something that's tailored to them. So we're just in the way, and we just need to help people have confidence in this. And I also think it's so important that we continue to study this and continue to gather the information. I mean, I think one of the faults of American medicine is we do a lot of stuff and we don't measure the impact. And I think that,
Yeah.
checking the outcomes is so important. We would have been nowhere if we didn't check the outcomes from Wisdom. And we're in the middle of Wisdom 2.0. So wisdomstudy.org, you can learn more about it. We're improving the algorithms for risk. We're trying to predict who's got risk for slow growing and fast growing tumors. We're also trying to work on integrating mammographic density algorithms. And I'm so excited about all that we can accomplish. But it's going to take a big concerted effort, and the insurance companies have to go along. I mean, I think it's a win-win because the overall resources are actually less. It does take some work to make a change, but I think we all need to invest in this.
It will changes once you start to do that, you're gonna have less mammograms, and the people that need the mammograms will be getting them, the people that need treatment will be getting them. As we start to wrap up, is there anything that I should ask you that I didn't ask you?
I think if people are interested in this area, again, please join us at the Rise Up meeting. Important questions that patients want to know. Can I ever have hormone replacement therapy? What if I'm suffering from symptoms or side effects, or are there things that I can think about? Is that always no if I've had a hormone positive breast cancer? Well, probably not. We know it's safe to get pregnant after a hormone positive breast cancer. So I think there's a lot of myths that we have that we don't have a lot of good data for. And I think that we need to answer the questions that people care most about. And I also want to say is the answer to, we don't have to make people suffer necessarily to get them a good result. And I think we need to be more cognizant about how we can do better about coming up with combinations that both treat symptoms and prevent symptoms from side effects and also reduce the risk from cancer. I don't think we necessarily have to make it that we choose one or the other.
Well, medicine is always changing, right? And so
Always changing.
as science changes, as we learn more, as we see more, I mean, I think we know very little about the human body. And as time goes on, we're learning very little very slowly.
And I think that's another thing that we have to do better about. And I would say to the listeners a couple of things. More is not better. More is just more. And sometimes more is worse. Sometimes more is better, but that we should endeavor to try and figure out for whom those things work, and that it just makes sense to be able to stratify treatments based on biology. And for our treatments, to make our treatments better, we need to do response adaptive therapy. When people are doing well, you can ratchet it down. When they aren't doing as well, then you have to, try and do more to try and prevent a bad outcome. These are ways in which we can make a difference. But, for anyone who has the opportunity to be part of a study, we're trying to make our clinical trials more patient-centered and more where people feel like they have more agency within trials so that they want to be part of them. But without the trials and without the data, we will
You can't go
continue
forward. Yeah.
to stay where we are. And I think that's the riskiest thing of all, we can't be afraid of making changes. That's the way we've moved everything forward. Otherwise, we would be still doing Halsted radical mastectomies on everybody and not curing anybody. So I think that's really important. I think, also, it's never true that there's an absolute answer one way or the other. It's all a balance of risk and benefit. And, people should be, we need to give our physicians and patients the tools to do shared decision making and to be able to find the level of therapy that's right for them.
So, Dr. Laura Esserman, thank you so much for joining me. The conference is February 19th to 21st. It's Rise Up for Breast Cancer and Women's Health. You can sign up by looking below, and the link is in. I'm going to put the link right in here, so you can click on that, and it will take you to riseup.ucsf.edu.
It's at the Nico Hotel in beautiful San Francisco.
You just had the Super Bowl there.
We did. I think people saw what an amazingly beautiful city this is.
San Francisco is an amazing city. Thank you for joining me. Thank you for listening out there. If you have questions or comments, as always, write them right below. Until next time, everyone, be safe.